Hello, welcome to Drugs Unwrapped with me, Rob. Today I am delighted to be joined by Tony Duffin, who is the CEO of the Ana Liffey Drugs Project. Tony, good to see you. Good morning. How are you?
Great, Rob. It's sunny in Dublin, which is unusual, as people will know. So I'm very happy.
Don't get your hopes up too much. Tony, before we start, is it all right if you would just explain very briefly the Ana Liffey Drugs Project, what you provide? And I know obviously you mentioned Dublin there. You're not just Dublin, are you? So
No.
if you were able to just explain about the service that you oversee.
Yeah, so really quickly, Ana Liffey established in 1982 was the first organised service based on harm reduction principles in Ireland. So very early on. A rich history of harm reduction, of low threshold work, working with people who use drugs. And obviously, I think it's obvious at this stage that people are not just people who use drugs, they are people who have other aspects to their lives, other, positive things and negative things that go on for them. So we cover a full range when we're working with people. It might be mental health, it might be homelessness, it can be physical health, etc. So it's we are a drug service, a harm reduction service, but we work with people who have some I suppose complex and multiple needs, and also have lots of positive things going on for them in their lives, which people often forget to mention. So we provide outreach services in the streets of Dublin and the Midwest, particularly Limerick City and around the Midwest region. And we will do everything from needle exchange. We will do case management work, quite in-depth pieces of work that we do with people. We support thousands of people every year, and we also have a nursing team. So we go into private emergency accommodation. We meet people on the streets. We'll meet people in their homes, and we work with people to set goals that they want to achieve themselves. And we work with them around everything from stabilisation to recovery and abstinence, through to just housing and, well, not just housing. Housing is a huge issue. Housing and other health and social services that people might need. We'll work through them and get them help. So it's never the same day twice here. And as I say, there's a lot of difficulties that we help people through. There's a lot of positive stuff as well. And part of the thing I think we'll talk about later is how harm reduction needs to talk more about the positives and the outcomes for people. But we'll come back to that perhaps.
Yeah, absolutely. So how long have you been at Ana Liffey for then, Tony?
I started on the 5th of November 2005. And I will step down from my position as CEO of Ana Liffey in the coming weeks on the 2nd of May 2025. So it's my 20th year, and
Wow.
it's been an enormous privilege to be the CEO of Ana Liffey. 20 years as CEO is a long time in one position. So it's as simple as the desire to move on and do something else. That's why I'm leaving. The project and the staff and the service users are just brilliant. Working with people has been an absolute privilege. And people go, staff members, project staff, managers, they all go the extra mile. It's just a great place to work. It's not an advertisement for Ana Liffey. It is, and people might say, "Well, you would say that you're the CEO," but honestly, it's an amazing organisation, and maybe I'll get into a bit more about that as well in a minute.
Yeah. Sold, Tony. When's the next flight? I'm coming over. Do you know what? I would have loved to have come over to Dublin and done this in person. I should have put that as a proposal, isn't it? But
everyone should come to Dublin. That's all I can say, or indeed to Ireland. it's always good to visit, right?
Yeah, I've been to Dublin twice. First time was my 21st, so I don't remember it too well, if I'm honest with you. And then the second time was obviously to come and see you, and obviously your work around consumption rooms, which we'll get onto in a little bit. But
Yeah.
but how does it feel knowing you got a couple of weeks left after the 20 years?
I think when people have, if people have who are listening have been in the role for some time and you're stepping down, there's a mixture of emotions. There's a bit of a roller coaster emotionally. You know, there's excitement and there's sadness and there's all those things. But more and more, it's more excitement about the future now. As I get closer to stepping down, but yeah, no, it is yeah, it's a mixture of emotions that I'm going through, and but mostly it's excitement now, which is great. You know, and I'm very proud of the last 20 years at Ana Liffey, and I shouldn't shy away from that. It is there's a lot that's happened here, and it's quite a different organisation to when I first started. Not doesn't mean that we've kept the good bits, you know, and we've expanded and we've developed, you know.
Yeah. How have services changed then in kind of Ireland from when you started at 2005? Like you said, in terms of when you started, it looks quite different to what it is now. So how have things changed over that time?
Okay, so whilst the last 20 years only seems like that to me, it's fair to say that you know, over the last, when I moved to Ireland in 2000, so people will be like, why has he got an English accent? I moved to Ireland in 2000. I moved over from London. My parents are Irish, and that's the kind of connection. And just around that time in 2000, it was the Celtic Tiger was you know, the economy was booming, and yet there was they were just developing, beginning to draw down, setting budgets and drawing down increasingly more money towards homeless services, which I was working with at the time, and addiction services. So I kind of moved to Ireland at an opportunistic time. I'd worked in London and in Melbourne. With people who were homeless or people who were using drugs or alcohol, so I had some experience that was useful here in Dublin, and got a job with initially with Dublin Simon Community, then with the Homeless Agency, which is now the Dublin Regional Homeless Executive, and then with DePaul Ireland. And there was work over those 5 years doing innovative pieces. But the reason I mention all that is because I can really, when I look back on it, I can see how the field has developed. You know, I remember working in one organisation, and at night time we had a security guard for 70 men living in this hostel, one security guard. And now, obviously, that would never happen. Now you would have a couple of staff, and they would be trained appropriately. And yeah, so I've seen how things have changed just in terms of just sheer volume of funding and sheer volume of staffing. We always we still have huge problems. You know, obviously, our homelessness problem in Ireland is, but similar to other jurisdictions, has just, you know, skyrocketed, and there's a lot of funding going towards that, a lot of staffing. Then there's the addiction services, much more funding in terms of community-based services like Ana Liffey, and within the HSE, there's a lot more going on. But yet we still have a burgeoning drug problem, and we have more drugs, and they're more toxic. But we know, and you'll know, listeners to this podcast will know that that we're working in the face of a multi-billion-dollar industry, an illicit industry nonetheless, but nonetheless a very dynamic industry. And if we weren't doing what we're doing collectively, things would be worse. So, you know, and we need to talk about what policies might work in the future. But yeah. I think how has it changed in the last while? Well, I mean, in terms of Ana Liffey, when I look at Ana Liffey, we went from, when I joined, there was 9 staff. And we had this building here in Abbey Street, and we had a drop-in downstairs, and it was a busy small service. Now we have 6 buildings across Dublin and the Midwest. We have a fleet of vehicles that support the people we work with, including 2 mobile outreach units, harm reduction units, that go out into the streets and do needle exchange, and sometimes the nurses go out with them and that kind of thing. And we have a nursing team, which we didn't have at the beginning. So there's a lot more professionals involved here at Ana Liffey. There's still great work. You know what I mean? You know, in terms of the interaction with people, we've retained our ethos, and I suppose in terms of, if I was to look back at big achievements over the last 20 years, it's retaining the ethos of Ana Liffey, the low threshold harm reduction, low threshold ethos. We went through a very large, we now have 80 staff. I didn't mention that, sorry. We now have 80 staff. And in the last couple of years, we've expanded. We expanded during COVID particularly. And last year we went through a restructuring phase. And the reason I mentioned that now is because we had an external consultant look at the organisation, speak to all the stakeholders, work through a new structure for us. But one of the things that he said, Jack Nadel said, was that when he went to speak with team members and focus groups and one-to-ones and such, without fail, everybody understood the ethos, but not just understood, could give examples of how they implement it in their day-to-day work. And as a CEO, that's a great, that is a great achievement. And I'm so proud of that. That comes from me and people like Dawn Russell, the Director of Services here, the managers, the numerous managers, all the staff, all knowing. And I think sometimes what people don't realise is that ethos is maybe something you see on a vision, mission and values statement document, but it's actually the glue that holds you all together. So health and safety is really important. Fire safety is really important. Financial probity is really important, making sure all the money is accounted for, all these things that you have to do when you're running an organisation. But quite often the ethos gets forgotten about. But if you want to have a CEO being interviewed on a podcast or on a radio program, and they're talking within their ethos of the organisation, then you know that the board's going to be happy. You know that your team's going to be happy. Similarly, if you have project staff in a meeting with their manager talking about cases, and they're all working, making decisions about from within their ethos of the organisation, then I know, right, if that truly is happening, then I can stand over their decisions, And indeed, if you want to win an argument with a CEO, make sure you're doing it from within the ethos of the organisation. You're more likely to win the argument.
Little tip for the future there, then.
Yeah.
In terms of trends, then, so you mentioned obviously, it's similar to us and all drug services, really, isn't it? You are kind of working against that kind of £1 billion market, What are you seeing in terms of in Ireland then in relation to trends? For us, what we've seen are kind of what we're hearing a lot, and what we're noticing in quite a bit of our data now is a lot more people accessing services for cocaine and crack cocaine. That's significantly increased, I would say, in the last 5 years in Wales. What are you seeing? And I guess my kind of follow-up question to it is, are you also seeing the drugs market being infiltrated with any forms of synthetic opioids? So for us, we're seeing nitazines, obviously fentanyl's had lots of attention in North America. Is that something you're also seeing over in Ireland?
Yeah, it mirrors that. It mirrors exactly that. We have had, I think, post-COVID, crack cocaine has significantly increased. And and nitazines. We've had incidences of quite significant overdoses that have involved sort of clusters that have involved nitazines. There was the first really obvious one to mention is the one that took place in November of 23, and that was I think it was around 62 overdoses in the space of 4 days in Dublin, and we would normally maybe have like an ambulance crews in Dublin would normally see about 3 overdoses in a day, so that was what my understanding was about that. We saw a similar one, I think it was July of 24, in Cork around that date. Similar situation, not quite as many overdoses, but certainly a very serious situation. And then more recently, in a prison in the Midlands, we had around 12 people overdose on what we thought would be nitazines. I'm not quite sure what it was exactly, but it was a synthetic benzodiazepine. That people had overdosed on, something around that. So we've got synthetics. It is the concern for everybody, I think, not just in Ireland but everywhere, that these. And I think, when you look at what's going on with Trump at the moment, in terms of the tariffs, and the discourse surrounding the impact that's going to have, the downturn in economies. We know from bitter experience that the illicit market adapts, and I don't know what exactly will happen, but if we go into a downturn in the economy, if we have a crash and it lasts for a while, we will all see drug trends change, and not good changes. Obviously, we're not talking about reducing drug-related harms. We're talking about increasing drug-related harms. 2009, we saw the head shop drugs shops proliferate across Ireland. Is it because we were in a recession? I'd say it was partly to do with that. It was definitely in the context of that. There was other things that were going on at the same time, but you can't ignore that Ireland had got, the world had gone into recession. Ireland was deeply affected in 2007, 2008, and then the years of austerity that followed. And we saw head shop drugs proliferate. Same time, we would have seen huffing butane gas on the streets come back. It was essentially gone. Then it was just a cheap form of drug use, So when people don't have money, and also it's not people who use drugs that decide on the drug trends. It's suppliers who decide on drug trends. Supply and demand. It's not demand and supply. They decide, and what gets moved in and moved out, and we have no control over that particularly. Obviously, the police and Coast Guards are trying to stop drugs coming into Ireland. Like when I talk about Ireland, this is everywhere, right? Like this is we are not stopping drugs in any jurisdictions moving through. It's them who decide what is going to happen next with synthetics or heroin or whatever it might be, cocaine, benzos. We have, I think it's fair to say, like yourselves, poly drug use. I mean, there is nobody we know who just takes one substance. I'm not sure there ever was a person who ever took one substance. But we really are well and truly, we acknowledge that the overdoses, etc., are all about poly drug use.
Yeah. Do going back in terms of that situation then in 2023 when you had 60 odd overdoses within 4 days, was there then like a quite quick response from like government or anything like that to say, okay, wow, we need to kind of like look at what's going on here, and then also ultimately put something in place to say we can't let something like this happen, as well as additionally what we've already been seeing prior to that?
Okay, so now there is a group that is very much focused on what you've just described. A very organised response at a national level in terms of emerging trends, emergencies like that. At the time in 23, you'd probably been around that time to, I don't know, a seminar or a conference about foresight, the idea of looking ahead, and trying to understand and react, and then planning to react and such. And like everybody else, I think we here in Ireland, we were doing the same thing. But honestly, the how it happened in Dublin for me, my involvement was it was about 8:15 in the morning. Got a call from my friend and colleague, Dr. Austin O'Carroll, who was dealing with an overdose, but he was concerned that that he had just been informed by the attending ambulance service that it was the eighth one that morning. So they had seen 7 already, which was very unusual, right?
Yeah.
He had to go off. He had to get off the phone. I carried on strolling, walking the dog, and called him back about 10 minutes later. And he said, look, I actually told you I can't talk. I'm dealing with another one. So that was 9, right? And it kept going from there to there. And then, of course, it was happening elsewhere in the city. That was just my experience happening elsewhere in the city. We immediately put out, got in touch with Dawn Russell here, the director of services, and we immediately started to work with the team to get as much information and naloxone, etc., out to people. And it was a kind of bottom-up approach. At the same time, my colleagues in the HSC were beginning to, at the national level, beginning to understand what was going on as well. And from their perspective, they wanted to find out as much as they could quickly, and get some tests done in terms of drug checking, and they did. And they found that as soon as they had some information that they could share, they did. And I think it was somewhere between 12 o'clock and 2 o'clock that day that a national warning went out, which was really, really helpful, because we were then able to, use that warning on top of everything we knew locally to share with people who use drugs and other projects, and not just Ana Liffey, but Merchants Key and all the other drug services. People were really getting informed, and so there was a good bottom-up and top-down approach, which is absolutely what you need. So much so that I was really impressed. The city council put up severe overdose warnings on traffic signs. So there's ones that light up and you can write whatever you want on them. Those kind of things. As people were leaving on Friday evening, heading off into home, those were advertising that there was a severe overdose concern, warning. And where to get more advice, which was great, and it was just brilliant to see all this. And I think it was a really good response, and I think we did save lives. It was a cluster. I suppose the question is, where did it all go? Obviously the guards were doing their thing, obviously trying to find out and seize those drugs, and then the HSE with the health service executive, the guards, the police here in Ireland, the HSE, our National Health Service, they were doing their thing, and community services like Ana Liffey and others were doing their thing, engaging with people, and people who use drugs themselves were getting the information out. So it was a really good whole system response. Was it completely planned? No. Why did it work so well? Probably because of the relationships that had been built up during COVID.
Okay.
We did the interpersonal relationships that built up during COVID really kicked into play. There was a crisis. We were just coming out of a crisis, so we knew exactly who to ring and who to talk to and all that sort of thing. So I think it was really helpful, and I think that was a huge benefit. The learning, I think, is that in the different other countries, other cities, you need to value your community-based services. You need to listen to them, and vice versa. You need the community services need to value the national and all work together. And I think if you do that, I think you've got and people who use drugs, of course. And if you do that, then you've got far more chance to reach people, with naloxone. This is what I got prepared earlier, and with advice and harm reduction advice, standard harm reduction advice, getting over to people and making sure that people use with someone else, waiting as long as possible, not using at the same time, because if you both use at the same time, there was nitazines, you could both be overdosing, etc., etc. So, just standard stuff, good stuff, that has saved a lot of people's lives over the years. So yeah, it was a difficult, terrible situation, but there was a great response that saved people's lives. I'm sure of it.
It must have been, like you said, those 3-4 days must have been probably some of the hardest maybe you've experienced.
Yeah, and I mean, nitazines haven't gone away. It's just that we don't, and I'm not, obviously, I don't want to jinx us. We haven't had a cluster for a while, as far as I'm aware, and of overdoses. So nitazines are out there. So the question is, what's going on? I think we're all trying to understand what's going on. What tends to happen with drugs that are causing a cluster of overdoses is they get removed by the suppliers. They get taken out of circulation. That doesn't mean they get destroyed. Yeah. They're likely to be cut further or turn up somewhere else, and cause it. I mean, who knows? I don't know, but was the cluster in Cork later on in the year related to the cluster in Dublin? Don't know, right? But yeah, there's an issue there, about the risks of those drugs re-emerging in the market. Yeah, absolutely. Especially at places like festivals where dealers often, will bring dodgy tablets, pills, powders, whatever, to get rid of away from their usual market, their usual customers.
Yeah. And environments like festivals bring their own complexities as well, don't they?
Oh, yeah.
Going on with that. I know in terms of when we were kind of chatting before, recording this episode, you kind of mentioned around harm reduction 2.0 is kind of a good time, I think, to bring that in. Obviously, talking about harm reduction, naloxone, and that's a kind of phrase that you kind of use, and you kind of said, it's kind of, harm reduction 2.0 is more than preventing overdose and spreading of BBV. So what else are we talking about there, Tony, in terms of what other kind of harm reduction things are important, you would say?
Okay, so I'm the chair of the Correlation European Harm Reduction Network, the advisory group, and I was at the European Harm Reduction Conference in Warsaw towards the end of last year, beginning of December, and this was coming up, this idea around needing to explain ourselves better, and whilst harm reduction, there is no agreed definition of harm reduction. There's multiple definitions out there, and they're pretty consistent, about neither promoting or denouncing drug use, but seeking to ameliorate the problems associated with it. And then people have different ways of describing that, and so on. But I think what we've done over the years is and harm reduction, the purpose, is to reduce harm, right? And part of those harms are bloodborne viruses and overdoses. But it's not the only thing we do, and we should continue to do those things as well. But we do have great outcomes for people that are softer perhaps than preventing death or injury, and those things need to be recorded if they're not being recorded, and they need to be shared across with people. So getting people into housing, getting people into treatment, supporting people to stabilise their drug use, supporting people to go into treatment and rehabilitation, recover. These are not, and the old problems that it doesn't really exist so much in Ireland at all. But I know in other jurisdictions there's kind of two camps around recovery and harm reduction, and there shouldn't be. I think that they very much work together. It's just that recovery does need to encompass stabilisation and abstinence. That's the way I would view it when I talk about recovery. And harm reduction services have always, or should always, build recovery capital, giving people the tools to support their recovery, whatever that looks like. So I think there's a lot to be said about what does harm reduction look like? I think, it should always be low threshold, never bar anybody from your services. And to me, from working in this field since 1993, oh my God,
not giving your age away there, Tony.
Right, that's the most important thing, actually. It's everything is important, but being low threshold is hugely important because that's the principle that instills creativity and innovation across the workforce, right? Yeah. What do I mean by that? So if you can't bar somebody from a service, right, and the expectation by your employer, like Ana Liffey, is that you have to find a way to work with people. That doesn't mean that somebody, that low threshold is no threshold. I mean, I've many times I've dealt with people who've been violent, and many times I've been with people who have trashed the place and all that. It's not about them coming back in to trash the place tomorrow, but it is about finding a way to work with them, maybe off-site, maybe in another part of the service, that you keep the engagement with people, because without the engagement, there is nothing. There's no therapeutic relationship at all. So you've got to keep in touch with people, or and also, there's plenty of services out there that will kick people out, and it feeds into that kind of the belief that the person isn't worth it, and that kind of thing. So they've given up on themselves anyway. Then you start giving up on them. So look, just keep engaged with people. Don't bar anybody from your services, not in its entirety, And then, of course, people say, well, what if someone hits somebody, a staff member? Well, that's what the law is there for, And if it has to be a situation of prosecution, then that's what it is. But equally, if not, then what other safeguards we put in place? Health and safety over the years has been used to exclude people. Health and safety is there to help you to include people. That's the way you should be looking at it. So there's all sorts of things. So sorry, I'm sort of going all over the place, but there's principles like diversity, celebrate. In this time when of intolerance across the globe, it is very important for us to double down on diversity, equity, and inclusion. Very, very important, and we are, and we do. So that's another element to it. So I'm just trying to think. I think I've mentioned most of it, but yeah, there's certain principles that really do underpin what harm reduction needs to look like as we go forwards into the future. And I hear it around the place. I don't know if you have, but people sort of talking about what harm reduction is and could be, should be, as we go forward into the future. That is more holistic, that is more, that explains itself better to the world, to funders, to stakeholders, to the communities, that we have services in, and also as a policy,
Yeah, I was going to say, and kind of come on to it, because I think for a lot of people, when your name is mentioned, many will probably associate you being a kind of a prominent drug policy kind of campaigner to a degree. But yeah, for me, harm reduction is, you got all that practice, and I got an email this morning around, trans people in terms of within that injecting community, and there's a significant lack of literature and resources and such, like associated to that community. So there's a gap there, and something that needs to kind of be built upon, and kind of harm reduction needs to kind of align with as well. But yeah, kind of you got all that kind of practice, you kind of got the policies aspect, and I know for you, drug consumption rooms was a big thing in terms of what you campaigned about. But I guess, do you just see kind of like harm reduction 2.0 policy being a fundamental part of that as well, in terms of that it does need to update itself, it does need to fall in line with ultimately what is required to support people as effectively as possible?
Yeah, no, I mean, things like decriminalisation of drugs for personal use, drug consumption rooms, making sure naloxone is as freely available and over the counter as it can be. Yeah, like I think that, you know, into my 33 years, is it 32 years? I'm going to lose track. You know, we definitely need to keep talking about progressive drug policy, that harm reduction mustn't be lost sight of within that brings together the different, not just harm reduction, but as I've mentioned before, already, recovery, but also treatment, rehabilitation, supply control, prevention, education, all the things that we've talked about over the years. But there needs to be, you know, new energy at play here, and a focus that is far more laser pointed at what works, but also learning from our experience. You know, like there's, I often say this, it's like drug policy from empathy, evidence and experience. You know, they come to the table with empathy, you know, understand, come with an understanding of how it must feel for other people who use drugs and have those complex difficulties, and then, you know, always, you know, work to what works, but also then, you know, listen to the experience of people who have been working at the table for years. Because I think that, you know, if drug policy were as simple as evidence, then we'd all be doing what works, right? It would just, but it's clearly not. It's far more political than that. It's far more complicated than that. We see that in the US and at the moment with the change of leadership there, and we see it at the CND in the last week or so. Yeah, things need to be very, very focused on, I would say, on those three areas. But no, I think that you asked me about the drug consumption rooms. So the drug consumption rooms, it opened in Ireland just before Christmas, the Saturday before Christmas, and that was a great thing. You know, it was a medically supervised injection facility, and it had been a long time coming. We certainly started lobbying or advocating for such a service on the 20th of January 2012. I remember the day. Yeah, and it was a journey. And by 2017, we had successfully advocated for and you know, done some pretty great work, really, the team here, to get the legislation over the line with the state. There's a whole paper on that. That was a great journey, and so it was sort of just over 5 years to get to the legislative point, and then it was another 7 years to get to the or more, maybe 7 or 8 years to get to the point where the service could open. And I'm pleased to say that it's over there. It looks great. The team are great at Merchants Quay, and they're working away and deliver a service which is now just part of the service landscape, you know, which is fantastic. And that's the thing. Like, there's all this kind of moral panic about, you know, drug consumption rooms, decrim, regulation, control regulation. But you know, once you introduce your policies, the world doesn't end. People can start getting helped. It's fine, you know. That was one of the things that I realised when I went to Portugal and visited there for the first time, with their, you know, their essentially very, very good diversion scheme, decrim. And it was said to me by Nuno Capaz, you know, what do you think happens in the morning after you decriminalise drugs? And the answer to that is nothing. The sun comes up, if you will. It might be raining in Dublin, but nothing terrible happens. But over the years, months and years that follow, things improve, and that's it. And all this moralising about, you know, drug use and whether the state still has a response, you know, in the decrim environment, drugs remain illegal, but it's just a far more human response, to people when they're they're not even looking for them anymore. They just, when they come across someone who's in possession, they refer them for some assistance, or
Yeah.
so yeah, if they need it.
Do you know, in terms of so yeah, you actually changed the law, didn't you, in Ireland, in terms of to
Mm,
allow for the
mm,
facilitation of consumption rooms or medically
yeah,
injecting
yeah.
centres, whatever terminology people want to use. What
Mm.
worked? What would you say? What would you pinpoint to that worked really well to enable that to happen? Are there certain things that you look back on, you're like, okay, that worked really well and that worked really
Yeah,
well,
it was
and they were
quite.
fundamental to that?
So when we said on the 20th of January 2012 that we were going to advocate for supervised injection facilities, and indeed we would look to run one as well, but that didn't happen for Ana Liffey. But the we didn't know what we were going to do. Right, there was no map. This was illegal. Right, there was no like. So we had to be pathfinders. We had to be great problem solvers. And when I say we, I mean the team here at Ana Liffey, and we had to advocate strongly in the media. So there was a lot of stuff that was going on. There was engaging with the media, traditional media, social media. You would have seen, Rob, over the years. I was down alleyways taking photographs of needles and syringes
Yeah, yeah.
all the bloody time, right? Trying to put it out to social media to keep emphasising that this is a very real issue for Dublin, particularly, and for other pockets of Ireland. But that was one thing. Then it was like the stakeholders, all the different stakeholders. You had the business groups, you had the civil servants, the public servants, you had the elected officials, TDs, or who were elected into Parliament, and the Senate, and you had to speak to their self-interest. You had to speak to each one. You had to tailor your message to business groups or politicians or to the health service. Clearly, supervised injection facility, one of the things it does, and one of the most important things it does, is save people's lives who are overdosing. Right. So that's really important from a health perspective. But from a business perspective, and people are obviously, business people are still, want to hear that people's lives are safe, but they're interested in football. They're interested in businesses doing well in the city centre, and you had to try and get the evidence together to explain to them that we can, if we don't do this, this is just going to stay like this. It's going to be injecting going wrong around the area. If you do give people somewhere to go, we can manage the space. The injecting behaviour reduces significantly, and the amenity of the area is improved, right? So they were the things we were doing. We were talking to business groups. Not everyone agreed. There was backlash. There was all sorts of things, but ultimately that was important. Then the real question was, we went and looked at. Marcus Keane, who was working here with me, was qualified as a barrister by happy coincidence, and he was half-time here at the time. We instructed him through our solicitor to prepare a document, a legal opinion, and he did that, and he came back with a 70-page document, and it came back with options. And to cut a long story short, the option that we could go for was to change the law, which then the question is, how are we going to change the law?
Yeah.
So then we had to figure that out. So we went to the voluntary assistance scheme of the Bar Council of Ireland. So basically, lawyers who help people for free. I make it sound a bit simple there, but there was a process. So we went to them, and we asked them if they would draft legislation that, if enacted, would allow for the existence of supervised injection facilities in Ireland. And they'd never put a drafting committee together. But this is a very long story short. They agreed to do it. They put that together. Marcus was a member of that, and the group, with very senior counsel, drafted legislation. It took a year, and then we were like, right. They were like, right, we've done it. It's done. And what are we going to do? Right. So the minister of the day was Ana Liffey TD, and I asked Aon if he would come to an event where Emily Egan, who is now a judge in Ireland, would say a few words and pass the legislation to me, and I would say a few words and I would pass it to the minister of the day, Aon Liffey, and he agreed to come, and he turned up, and we did that, and he said really he was just saying, look, I don't know exactly what's going to happen with this, but I'm going back to instruct my civil servants to start working on this. And that's what I did. And then we worked with them. We would, Marcus and had been involved. So there was a lot of backwards and forwards and, talk about particular words and legal terms and that legislation that the Voluntary Assistance Scheme of the Bar Council of Ireland drafted on behalf of Ana Liffey there was a direct lineage to the legislation that ultimately was enacted and signed off by the President of Ireland in May of 2017. So I doubt that will ever happen again. I just don't think it'll happen again. I think it took, that kind of problem solving, pathfinding, a little bit of not really understanding what's possible, so therefore you just ask, that kind of thing. It was a very proud day when the legislation was been through the Oireachtas, through the Dáil and the Seanad, and essentially was off to be signed by the President of Ireland, which would allow for the existence of injecting rooms in Ireland. It was a fantastic achievement, and very proud of it. It's good.
Yeah, you must be. Any other reforms that you would like to see in the near future in Ireland?
Yeah, no, I mean the big one really is decrim. I think decrim is it's on the cards. Health-led approach has been on the cards since 2017. There's been a lot of talk and a lot of work in the background. I think it will happen soon. I think that's really welcome, but I don't think it's going to go far enough. We want to see people get every opportunity, and my understanding is that it won't be, because the system that has been described in the public domain and things that have been worked on elsewhere doesn't give people every opportunity. So every time you get, it's going to be once, at best once, arguably twice, but certainly the third time you go to court. So, we need to make sure that people get every opportunity. There's no need for people to have any kind of criminal justice footprint for the use of drugs for personal use. So that's a big piece of work that needs to be continued. Even though, as I say, it's very welcome that we're moving in the right direction, but we need to keep pushing for more. There was a citizens' assembly on drugs use. I'm not sure if your listeners were aware of that. There was in 2023, it finished up in October 23. Reported on at that time. There was a citizens' assembly, which is basically a group of citizens, of 99 citizens, plus a chairperson, Paul Reid was his name, who were tasked with looking at how to respond to drug use in Ireland. Okay, and they spent 7 months deliberating and being informed about all the issues. I mean, it was quite the consultation. It covered, it had international speakers, experts, national experts, people with lived experience, families, politicians, civil servants, public servants. Everybody was in. I was in twice. They probably got sick of me. And talking about different things. And it was fantastic. And they came back with, I think, 36 recommendations. Those recommendations, absolutely, they should be implemented, right? The process for a citizens' assembly is you put together a committee in our parliament, cross-party, looking at that, and then they make recommendations. Long story short, hasn't been implemented yet. government is only forming. We've had problems getting our committees up and running. So hopefully we will see some movement on the Citizens Assembly recommendations. We've also got the process of a new national drug strategy for Ireland. There's a looking back at the last number of years for the previous national drug strategy and into the future. So it's a bit of a year where we're kind of, it's kind of things got a bit quiet on the drug policy front, whilst the department works on things and consultation happens, and people are being asked what they think and such. And we'll have a new national drug strategy. I hope and I expect that the Citizens Assembly on Drugs Use recommendations will be in there. I think an interesting one is this. There was a vote on whether to regulate and control cannabis at the Citizens Assembly. And it was very, very close, but ultimately there was a tiny majority that said that they wouldn't. I'm just, like the exact wording is online. Yeah. They wouldn't recommend the regulation and control of cannabis, and that was the way it was. I suppose the interesting thing for me is that there was a number of people out of those 99 that didn't make it on the day. I think it was about 8 people, and God only knows if those people had turned up, which way it would have gone, whether it would have been a different outcome, or whether it would have been a similar sort of a more robust outcome in terms of weighting it against regulation and control. I think that we need to keep talking about it. I think that it was so slim that it could have gone either way. That it, of course, went one way, and the recommendations are clear on that. It doesn't recommend it. But I think as a country, there is an awful lot going on across the globe with different types of regulation and control of cannabis, whether it's a free market in America and Canada, etc., which I wouldn't agree with personally, or the likes of the cannabis clubs in Malta, which we should be looking at, those kind of things. So I think that we should be talking about it still. I don't think it should be closed down. I think we should have some sort of action in next national drug strategy, ideally, that keeps the discussion going. But we've got terrible problems with cannabis in Ireland. We've got terrible problems with synthetics, HHC and such, as I think you have elsewhere in Wales and such. I just think we need to keep it all on the table in terms of discussion.
Yeah. Do you know what? When you said that about cannabis and potential regulating it, and it kind of the majority saying no, I was actually quite surprised given some of the recommendations. I was like, okay.
I mean, I think people are fearful of a kind of free for all, like similar to the alcohol market, the alcohol beverage industry, and I wouldn't support that. Here in Ireland, I think, I don't know. I just think people were. I don't know what they. I can't speak for them, but sure. I don't know why they went one way and not the other.
From your knowledge, then, Tony, obviously, working with correlation across Europe and such like, was the Citizens Assembly quite unique? Because I think, is it something that happens in other countries you're aware of?
So it's deliberative democracy, and you can have different types of exactly how they're put together, but it's not unique. It's just that Ireland's one was put together by the state. Okay, so which is important because that gives it's inside the system. Citizens' assemblies can be outside the state and can be brought together by stakeholders, which just has less clout. I'm not saying that they're not valuable, but it's just not inside the system. So it's not unique. Now, we don't have any planned in this programme for government. There's none like the department that was managing the Citizens Assemblies. We've had a number over the last sort of number of years, 10 years or so. That's been wound down now because there's no point, because there's none in the programme for government. So it could be reinstated if there was another programme for government, but at the moment there's no more. So I think it's definitely worth a process that's definitely worth other countries sort of looking at for these kind of contentious policy issues. when the politicians seem to be unable to make a decision, they put it back to this kind of deliberative democracy structure where they go, right, okay, have a look at this for us and come back to us with your recommendation. That doesn't mean that the government has to follow the recommendations of the Citizens Assembly, nor the committee that then reports back. But I think it's foolish to ignore it all. When people have put so much time in, it would be foolish to ignore it. So I think we will see movement on those. I hope so anyway. The recommendations from the Citizens Assembly. Yeah. So I mean, drug policy moves very, very, very slowly.
Yeah.
have you noticed? Not just in Ireland, anyway, right?
Yeah.
The quickest I've ever seen anything move was during COVID. We weren't allowed in Ireland to have benzodiazepine stabilization prescriptions for people, but during COVID we were. And that stayed. That is still an option that's open to the GPs and products. We saw our methadone prescription waiting list go from 12 to 13 weeks to 2 to 3 days because the caps were removed, which couldn't be done before. So we know that much of this stuff is man-made, and we know that these are decisions that can be made. I know that these decisions cost money as well, but I think I thought COVID, and I think it just was an eye-opener as to, not just here but everywhere, as to what can be done when we need to.
Yeah, we saw similar in terms of COVID as well, like some methadone prescribing, Buvidol prescribing, in terms of, systems were in place prior, and then suddenly out of nowhere, these things can be done right there and then. So it was really interesting with as well. And I think going back to the Citizens Assembly, kind of looking from the outside, you make a great point there. There was actually set up by the state, so it was already in the system. But also, I think quite powerfully, and you said as well, you shouldn't really ignore. And I would say it's quite powerful in that it's the citizens ultimately. It's kind of everyday people that have ultimately kind of voted on these recommendations. And when you have that from your population, it's like, well, I think you kind of got to go with it, to a degree, I would say. So, it's really interesting.
Absolutely, you got to hope so, right? Otherwise, it's like, what was the point? And I mean, my God, I don't think we'll ever see that level of consultation again. Certainly not in my lifetime, right? I mean, I'd waited 30 years to see it in the first place, anywhere between the UK, Australia, or Ireland. So, I mean, in fairness, actually, you'll know that in Sydney, they had. Not a Citizens Assembly, but a very focused period. I don't know the language they use, but in their parliament, they took a number of days to really focus in on drug policy, and out of that came, things like the supervised injection facility in King's Cross. So that not the same, something that was really focused.
Yeah. Tony, we could go on. There's obviously lots of work that you do in Europe, and kind of, I know you're a bit of a globetrotter as well. So, but yeah, kind of tap into your knowledge and expertise. I think we could definitely do at least a couple of more hours and stuff. But no, good luck moving forward. I hope obviously when you come back over to Wales, and we got a big ketamine conference coming up next month, so forget some of these other countries you're going to, Tony. I think Wales should be your one of your next destinations.
I come to Wales anytime. I just remember when it was. I'll tell this story and you can decide whether to keep it in or not.
Go for it.
Before Glyn once was in Cardiff, and he decided they were running a conference, and he thought, oh, there's Tony Duffin. It's a nice Irish sounding name, and Ana Liffey Drug Project. That's a lovely Irish sounding, and it's in Dublin. So he rang me up. I answered with an English accent. How do you think he was about that?
I'm sure he was delighted.
You might want to leave that one out. Anyway, yeah, no, we got on very well. And I went back twice to do 2 different conferences. But yeah, he was a little disappointed with my London accent.
Yeah, I think the first time I met you was, you came and talked about methadone at our wow, that must be about 2013 or something like that. And obviously we've had Dawn over a few times as well, haven't we? So yeah, great relationship with you guys. But yeah, moving forward, Tony, good luck. I hope you enjoy the last few weeks at Ana Liffey.
Thanks, Rob.
And yeah, good luck, kind of your new ventures and such.
Thank
like.
you.
And yeah, hopefully we'll kind of cross paths again sometime soon.
Yeah, look, thanks for the opportunity. As it comes to the end, it's nice to do something like this and to talk about the last little while and Liffey, 20 years.
Absolutely. Tony, thank you very much. To everyone else, we will see you soon. Bye-bye. If you have been affected by any of the issues discussed in today's podcast, please reach out. Barod have a free and confidential live web chat service that is available 7 days a week on our website at barod.cymru, where you can chat to a trained support worker. Alternatively, you can contact Wales's National Drug and Alcohol Helpline, Dan 24/7, either by calling 0808 808 2234 or text Dan to 81066.